call the meeting to order and get started. And the first presenter that we have on the budget is the Mississippi Department of Health. And I would like to give Dr. Edney the floor.
State Department of Health. And first of all, I want y'all to know that we are always grateful for our appropriation. And, you know, as we are discussing needs at the agency, that I will make a commitment to everyone at the Capitol that I treat the money at the agency just like I would as a good steward of the money at my church. That is critically important money for improving the health outcomes of Mississippians. And at the agency, we can squeeze a dollar pretty tight. I've included for you, and I just put it in a handout so you can see more easily. Really, what is driving us at the agency is the reason I actually accepted the position and left private practice was looking at our Commonwealth health scores. And you know, I tell people when I'm making copies of this graph, I have to be careful because a lot of times the copy machine will cut us off. We're so far to the right and down so low. And then I encourage folks just to know that what we're seeing with our scorecards, and that's based on the highest rate of maternal infant mortality, very high rates of amputation for diabetics, high rates of hemodialysis, undiagnosed diabetes and hypertension, opioid epidemic, all the things that we're up against, you know, that these are solvable. And we may be at the bottom today, but we don't have to stay there. And through legislative leadership, y'all moved us off the bottom of education. And I'm just begging for partners to help us get us off the bottom with health, because we have too many Mississippians who are dying prematurely. We have too many who are aging with poor health. And we have too many people struggling for access to care, which is where we come in. And we have committed, coming out of COVID, coming out of pandemic response, that we are pivoting back towards the core responsibilities that you've given to the Board of Health and myself through statute, that it is our statutory responsibility to work on reducing maternal infant mortality. Y'all have given us that charge. You've given us the charge to improve outcomes from diabetes and hypertension. And I'm taking that charge very seriously. Mm-hmm. And to do that, I've got to strengthen our county health departments.
I agree with you. That's kind of been my platform for a while.
Great. Well, so that you know, I need 150 nurses today. And because it's not just the county health departments, but we're also standing up the Healthy Mom, Healthy Babies program, which is to reduce maternal infant mortality. And so between that brand new program, and that is a nurse case manager program in the home, so that the moms don't have to come to us, we go to them. And we walk that mom through her pregnancy and through the baby's first year of life. And we are going to do everything that we can to keep her alive.
Dr. Edney, I honestly, I'm shocked to hear you say this. I actually did an interview on WLOX several months back, and I discussed exactly the parameters that you're talking about and how the county health departments were once run. My sister-in-law retired, and she was one of those that took care of the pregnant women. So I don't know how other legislators feel, but personally, I am very happy to hear you saying what you're hearing.
Well, thank you. And
what you're saying.
We're committed to that. I can't do it with my current workforce. Mm-hmm. I don't have enough. Since 2016, when we had the initial appropriation cut, we've lost a lot of nurses. Mm-hmm. And then through COVID, we've lost even more. So that's where that 150 number comes from. We requested 100 with our budget request. At this point, I'll take whatever I can get. We've got to have some help at the county health department level. And then it's important to understand that 80% of our funding is federal. Mm-hmm. Those federal dollars are tightly managed, and I don't have a lot of control of them. I have to do what the feds tell me to do with them. The state appropriation allows me to pivot and go after problems in a much more nimble fashion. So our state-funded nurses, I call them our Swiss Army knives. They can do just about anything we need them to do versus the federally funded nurses can't. They're very restricted.
Mhm.
So that's why the state appropriation for us is precious. If we're going to be able to expand anything,
Mhm.
it'll have to be through our appropriation. So the very modest ask that we have is not to expand the agency,
Mhm.
but it is to strengthen the safety net. Y'all know well what's going on in our rural communities, our rural hospitals. That's another statutory obligation that I have, is to work in that space. I'm driving to Greenville tonight to meet with their leadership. The healthcare access in the Delta is becoming scary, and it's not going to fix itself. So what we're doing is plugging the gaps, which is our role. And so I have to strengthen the safety net. And we're doing that through partnerships with FQHCs and free clinics. But we got to stand up our role at the county health department. And I need staff. I don't have enough.
Well, that is exactly what I said on my interview. I hope somebody heard it, and I'm so glad that you and I are looking at the same parameters to coordinate this care between community-based mental health centers, FQHCs, the free clinic network, and the nonprofits that have health care in the area. So, the other nonprofits that are not in the free clinic network, but you got others. So I totally agree with that approach. And I hope that others do.
And I'm convinced that it'll work, Senator. I really am. I really believe with all of us coming together, and it's going to take all of us, we'll get off the bottom.
I agree with you.
I would not be standing here today if I thought there was no hope to get off the bottom.
And I think part of it is people don't know where to go for the services. And if we can do some type of coordinated effort to, and let the health department lead that, to let people know where these resources are outside of the health department, if they need something that the health department cannot provide, to where to go to get these services that are already there and provided by the state. And I know we got some people in here that represent some of these other entities, and I want to utilize all of them.
Absolutely. And we're happy to partner with anyone who's interested to have the same mission and to get us off the bottom. We are, unfortunately, as you see us do more in the county health departments, that means we're going the wrong way. Reason we haven't been doing as much in the county health departments because people have had access to private clinics, which is where they need to be. The county health department does not need to be a medical home.
Right.
It needs to be a place of treatment of last resort. When you can't go anywhere else, you can come to us.
Right.
And so we got out of perinatal care because there wasn't a need for it. Now there's a need again because of access to care. So certain counties, we're looking at standing up perinatal care again. We're seeing populations that don't have access anywhere, and that falls to us. We're going back to looking at just some basic primary care provision, using telehealth, which will help us a lot, keep our expenses down. But there are areas of the state where there's no primary care or no pediatrics. And, we're only going to plug holes. We're not going to compete with anyone. I don't have any resources to compete. Don't want to compete. But there are holes that have to be plugged, and I see it as our responsibility to do so. But then, we have to be strategically thinking about these top 3 problems that are killing us: maternal infant mortality, diabetes and its complications, and the opioid crisis are driving our numbers horribly down. And then access to care kills us on our scorecard. So we're going to do what we can with access to care. I know y'all were working on those issues, but we're attacking those top 3. And a very big clinical issue that we're going to be doing immediately is increasing the opportunities for screening in Mississippi for diabetes and hypertension. So one of our problems is half of the diabetics in Mississippi don't know they have it, which means they don't have a doctor to get a checkup. And so they find out they're diabetic when they go to the emergency room and their sugar's 400. But we've already lost ground at that point. If we can catch them early in the disease and help it get managed, then the rate of dialysis goes down. So we'll have fewer dialysis patients. We'll have fewer amputations. The Mississippi Delta has the highest rate of lower extremity amputations in the country, and people will live longer. So we're committed. I've given a mandate. Everybody coming in to any county health department for any reason will be offered a free blood sugar check and a free blood pressure check. And if it's abnormal, we'll step in through our providers, but more importantly, we'll get them to a medical home so that they're taken care of and they have a better chance with their diabetes or hypertension. We've got to catch things early, and that's what we've not been doing a good job of. So we're committed to doing our part. I can assure you that any increased funding is going in that direction. It's not going to stay here in Jackson. It is going out to the county health departments. It's going into the Healthy Bombs program. And it also needs to go into the reworking of the state health plan so that that is a document that will be useful to you as you're doing healthcare legislation. We're doing a total rework of the state health plan using the data that we have, and it specifically is going to address the rural hospital crisis. And it's going to show you exactly what's going on and then give some thoughtful strategic recommendations that will be useful to y'all as you're doing your good healthcare work. So that's where we stand. I'd be happy to answer any questions.
Would any members have a question for Dr. Edney? Comments? Well,
Questions on the rural water or the ARPA issue?
well, I don't have any specific questions. I think we've laid that out pretty clearly as to what you have to go through to be able to get that. I mean, you might want to provide us a status update of how much has been awarded or something to that effect. I mean, if y'all have that on
You
hand.
got the expert right here.
Okay, and then we'll wrap it up after that.
So, Madam Chairman, members of the committee, just a little quick update on the ARPA Rural Water Association Infrastructure Grant Program. 287 applications were received. It was very popular. 140 of those were selected for funding. So out of 287, only 140 were able to be funded. That's for a total of $286 million, which that plus the administrative expenses on that fund, the full amount that was authorized in the last session. We had applications from 74 different counties. 64 of those counties were funded. 27 round one projects are considered shovel ready. So that means they're ready to get to work immediately. We're working on getting the grant agreements done now with a plan to have them executed by the end of January with all of the recipients. And then it looks like the list that was provided to the Legislative Budget Office of all the applicants, as many other projects that still remain for about 247 million additional dollars that could definitely assist in the infrastructure.
So you still have that much left. And so those people that might have been turned down, has there been any contact to them as to whether they need to maybe resubmit, change a plan? Is there been, or has it just been left up to them to contact y'all?
So those that we've notified that they have been funded are the ones we're working to get the agreements with.
But if they weren't funded, it would be up to them to communicate with y'all and kind of find out why they weren't funded or what they needed to do to try to maybe get funded with what y'all have left. Is there an opportunity for them to resubmit?
There's no balance left.
Oh, I thought you said there was a balance left. I got you. You spent it all.
We spent it all.
Okay.
Excuse me, but if you look at the list that was provided, there's a number of projects that are great projects that just weren't funded because there wasn't enough money.
I believe DEQ had some left on their projects.
Really?
I think they did for a second round, but y'all spent it all. Okay. Well, I appreciate that. And that's what we wanted to do. We wanted to utilize it and get it working as fast as we could. Any other members have questions since Senator Hobson has come in? If not, we appreciate it. And, as always, stay in touch with us. And I truly appreciate, Dr. Edney, your presentation and your philosophy with what you want to do with the health department. And I'm going to reiterate, I know how it did work because of a family member working there. And I know the people that served that were uninsured and didn't have care. I mean, I know that y'all sent the monitors home with the women when they were, having preterm labor. I have family members utilize that. So I'm more well versed than most people. And I feel certain in my mind that that's the way to go. I don't know how other legislators feel, but I know that it worked. And I know that it saved lives and it saved babies' lives. So thank you. Okay. Are y'all ready? Okay. Next, we're going to have the Department of Mental Health come forward. We're scanning the crowd to see if we saw y'all here. Okay, thank you. Welcome today. We're glad to have you, and just proceed and tell us where we are and what you're asking from us.
Thank you. Thank you for having us today and an opportunity to present our FY24 budget request. You're receiving two handouts. The first one's just kind of a one-page snapshot of what we're requesting. The second has some additional slides and information, but I'm really going to just work from that one page. So to start off, I just want to provide a brief snapshot of what our agency does. We have 700 grants that we provide to community providers for children and adolescents who have serious mental illness, adults with serious mental illness, people who have intellectual and developmental disabilities, and substance use disorder. We certify and monitor 136 providers across the state. We're responsible for credentialing about 3,700 staff in the state's mental health system. On any given day, there's about 1,000 people at our state hospitals receiving treatment for acute psych, forensics, child and adolescent substance use, nursing home care. On our regional programs for intellectual and developmental disabilities and community homes, on any given day, there's about 1,300 people receiving services there as well. And then we also have responsibility for the IDDD home and community-based waiver that's serving around 2,700, and the 1915I for IDD that serves another 1,100. So it's a very large number and variety of services that are provided through the system. Over the last several years, there has been a focus on the expansion of community-based services and to have those services available to where you can prevent that need for higher level of care. So much of this presentation focuses on that. As you know, there is a court-appointed monitor through the DOJ litigation, Dr. Michael Hogan. He's produced 2 reports, and in those reports, he's highlighted areas that we need to work on, and he's also highlighted areas where progress has been made as well. This past fiscal year, we had a decrease in the number of people served at the state hospitals, right at about 6%, and we had an increase in the services in the community, particularly those intensive community services that help keep people out of the hospital, like PACT, ICORD, and ICSS. Just to give you a little success on that, PACT is Programs of Assertive Community Treatment, and it's the highest level of service in the community, and it's for people who've had multiple hospitalizations. There were 760 people served in the state in PACT teams last year, and a 4% readmission rate. So you have these individuals who've been to a state hospital multiple times, and they're receiving this intense service in the community, and only 4% had to be readmitted to a state hospital, which is a phenomenal outcome. One of the things that has also been a focus, and I want to go ahead and address it, is the wait list and individuals waiting in jail. There's been a lot of attention and focus on that. We are glad to be able to report good numbers. In January of 2022, we had 119 people waiting for an acute psych bed across the state, and 119, and 41 were in jail. Over the course of the year, we've been able to increase that bed capacity back. And today, there's 17 people across the state waiting for an acute psych bed. 5 are in jail. 5 are in a same level of care hospital, and 5 are in a crisis stabilization unit. And there's 2 at home. So if you look from January to now, there's been an 86% decrease in the waiting list.
And is that because of the new beds that were opened up? Or what do you attribute that to?
I think it's several different components. It's some other programs that have also been started in the community, but it is directly related to the increase in the wait list was at the highest when we had the fewest beds available based on staffing. So we've been able to increase that staffing and open those beds back up, and the correlation is a decrease in the wait list. Absolutely.
That's the number one complaint just about.
That's
that we
right.
all get. So
That's
I
right.
appreciate the fact that that has improved.
Absolutely. So our request, we are requesting $246,803,322 in general funds. This is an increase of $25,183,576 from FY '23. So of that general fund increase, 15 million would be allocated to recruitment and retention efforts to increase our capacity to serve people in our programs. So the number of people that we have the ability to serve is directly tied to the number of staff that we have. We have 24/7 care for vulnerable Mississippians. If you're at a state hospital and for acute psych, you have been court committed, it's a danger to yourself or others. If you're on the IDD regional program side, these are individuals who have a high level of need. So it is 24/7 care, and many times it's one-on-one care. So the number of staff we have directly relates to the number of people that we are able to serve in a safe environment. 5.1 million is this increase in the service budget, and this is tied to CSUs. 4.494 million is the service budget for the IDD home and community-based waiver, and 504,159 is for the residency program at Mississippi State Hospital. So I'm going to break that up for you just a little bit. I think if you talk to any healthcare executive, they're going to tell you that the problem they're facing most is staffing challenges and staffing needs. So to break down that request for staffing, we have 10% increase in direct care salaries. So what we consider in this category is support care professionals, which is what we used to refer to as a direct care worker, RNs, LPNs, and behavioral health specialists. This is right at 2,900 employees. It is a 5.1 million increase in general funds. So our support care professionals, the minimum begins at $18,216 for support care 1, up to a support care 3 minimum is $24,000. Our goal is to have the average support care professional by FY '25 making $30,000. That is our internal goal. This request, this 10% this fiscal year and this additional 5%, the funding for this will help us reach that goal. When I took this position 2 years ago, one of the first things I did was I increased it by 20%. And then we did another 10% in October and then another 5% next year.
Where would those support care professionals that you're talking about, what brick and mortar place would they be working?
All of our programs.
Across the board?
That's right. Mississippi State Hospital, East Mississippi State Hospital, Specialized Treatment Facility, North Mississippi Regional Center. And you have to, there's staffing ratios, and you have to have a certain number of support care professionals. That's right. That's right.
So is that your greatest need over nurses? I'm just curious because, I mean, we hear like Dr. Edney needs nurses. And I'm just wondering, is that your greatest need, or is it nurses?
Right now, it would be direct care professionals. We've put a Band-Aid on our nurses, but I mean, I will tell you, we have right at about 202 nurses that are in like nurse 1, nurse 2, nurse 3s, and we have 194 LPNs. But we're still more than 100 down in nurses across the state as well. But direct care, that's the lower salary as well. So it's just harder to recruit. So let me give you an example. You can choose to go work at Wendy's or Chick-fil-A or Hobby Lobby at $15, $16, $17 an hour. Well, if you're in a PN and that minimum salary through this, through SPB, the salary that was set, you're making about $12 an hour. And it's direct patient care in a 24/7 state hospital or IDD regional program.
And I think the community-based mental health centers are probably having that exact same issue that y'all are having, because I've seen the turnover with that and how that affects how that place functions.
Yes, ma'am, they are. The crisis stabilization units across the state, they've at times had to decrease their bed capacity as well because they don't have a nurse or they're short staffed. So it absolutely, staffing is the number one problem, is staffing. All of the other problems usually tie back to that. That's the largest part of the request. We do have 1.6 $8 million in in-range salary adjustments. So what this is it's non-direct care employees. But SEC Squared was wonderful. It gave us some tools to be able to use. It set ranges and we can move within those ranges. But one of the kind of unintended consequences was compression that occurred. So to give an example, you have the LPNs, licensed practical nurses. They all moved to this minimum salary that was set. But then you have your LPN that had been there 20 years at that salary, and then your LPN that you hired yesterday at that salary. So these in-range salary adjustments were based on the number of years you've been employed, and they ranged between 2% and 8%. So the longer you had been employed with the agency or the state, you had the higher range in your adjustment. So that helped address some of the compression issues that were faced. $2.5 million is for shift differential for support care professionals. Okay, again, this goes back to those lowest paid salaries, support care professionals. It's a 24/7 program, so you have 3 shifts, A, B, and C shift. The hardest shifts to cover are B and C, your night shifts. So this provides shift differential. So if you're willing to work a B shift, you get a 10%. If you're willing to work a C shift,
Gotcha.
it's 15%. The other items requested for funding is the additional 5% for the direct care, some longevity increases, workforce needs specific to agencies. So in certain areas of the state, a program may be struggling more with security or maintenance, and it gives them the funding to be able to move within those ranges set forth by SPB. $5.1 million is around crisis stabilization units. So in his report, the court monitor, Dr. Hogan has stated that Mississippi has the pieces in place for a crisis stabilization system. We actually have more crisis stabilization beds than a lot of states do. So one of the things that we want to try to make sure is they're operating as intended and they're diverting people from a higher level of care, but looking at certain areas that could need more.
Yeah, I hear that some don't get full, but others always have waiting list. And there's some way, we just need some way to coordinate that between those different regions, if possible.
That's right. Well, one thing that we have a goal of this year is to have more of a transparent bed registry where all of the beds are included and you can see where the vacancies are across the state. That's one thing that we want to accomplish this year. With those CSUs though, in the remedial order, we have to have a certain number in each, with each.
Mhm.
So the order specifically states that Region 11 has to have 4 more beds in Adams.
Mhm.
So this funds that, and then 4 more beds in DeSoto County. We do not currently have a crisis stabilization unit for people who have intellectual and developmental disabilities. And this would begin a CSU for IDD. Many times these individuals are inappropriately committed to a state hospital. And you might not have a private provider that will take care of that individual because of the high level of need and care. And it's not appropriate for an ICF regional program. They're in a crisis situation. So this would start an IDD crisis stabilization unit for the state. It would also provide $1 million of funding for a diversion center in Forest Lamar counties. And they have a lot of support locally. They've come together, pulled together a great plan. This would provide $1 million for operational expenses.
Yeah, I'm well aware of that.
Yeah, that's moving good.
One question before I lose my train of thought. On the different community health regions, mental health regions, like if certain ones, like we said, stayed full, is there a way, or could there be a way to get a patient that might be in a jail in one place because there's no beds or nowhere to put them, and maybe move them to a different region and have some kind of payment solution for another region to take that person, outside of the jurisdiction of the one that they live in? Is there any kind of way or thought process, or is that anything that would be feasible? Because it makes no sense to me to have beds in one region that stay open and then others have people sitting in jail or somewhere at home wreaking havoc and not getting cared for if there was a bed open somewhere else. Because honestly, the money comes from the same tree.
That's right. So that's already in place. We need to operationalize it better.
Okay.
That's where a bed registry will
Yeah.
help too.
Okay. Well,
More
thank you.
formal
That's
bed
good to know.
But so if you have if you have Region 8's Crisis Stabilization Unit in Brookhaven, which is almost always full,
Mhm.
if you have another CMHC that has a CSU and a bordering
Mhm.
catchment area,
Mhm.
absolutely. As long as law enforcement will transport
Mhm.
or the family can transport, as
Mhm.
long as transportation is available, you can cross catchment areas. We look at those CSUs as a statewide basis. Where are the vacancies? How can we move? And we're moving towards that with our hospital.
I appreciate that.
If there's a vacant bed and there's somebody who needs treatment, we need that person in that bed. That's how I look at it.
Right.
So the last thing on the CSUs are currently the state funds a crisis stabilization unit in Hines Behavioral Health, Region 9, for child and adolescent. It begins at the age of 6 to 18. So what we are proposing is to add 8 beds in North Mississippi and 8 beds in South Mississippi to enhance the availability of crisis stabilization beds for children and youth.
Desperately needed.
Absolutely. Then the next item is the IDD home and community-based waiver. So this is for individuals with intellectual and developmental disabilities. It is $494,000 in general funds. This is the state share of support for the ability to enroll up to 350 people off of the planning list and into receiving services. So we're serving right at about 2,700 people through the waiver right now, and the planning list is now 2,700. So we have as many people on the planning list waiting on services as we do that we're serving.
So you're serving 50% of the people that need placement.
So yes, also though, if you look at that planning
Mhm.
list, about 1/3 of the individuals are receiving services through another way, through maybe another Medicaid waiver or the 1959. And then some of the individuals are on the planning list for future planning. They may not need the service right now. But what this funding would do is it would be able to enroll up to 350 off of that planning list and add them into receiving those services. The waiver is the mechanism for individuals to be served in a less restrictive environment and to remain in their communities and in their homes and in those local services. So the last item is the Mississippi State Hospital Psychiatry Residency Program. So I'm sure you know that Mississippi and most states in the nation, there is a shortage of psychiatrists. There's about 170, 180 in the state. Statistics show we need about 350 to 400 psychiatrists. So 2 years ago, Mississippi State Hospital began a residency program. And the first year they had 6 residents. And then this past year, 6 more residents came into the program. This past year, there were more than 500 applicants from across the nation apply to get into this program. So this funding would be for the salaries for the next 6 residents next year. So the goal is in FY25, you would have 24 psychiatrists that have gone through this program, and hopefully many of them will remain in the state.
So do we have some kind of incentive or anything to keep, I mean, you know, if we're training them and they're going back to their state, I don't know how much benefit that is. So have we looked at some way to try to keep them here like the rural physician program does or something like that?
All of that's being coordinated and then information shared too, but it does, studies will show you that if you train them in your state, you have a higher chance of them staying in your state, which is why we wanted to begin this residency program. At Mississippi State Hospital, they're having the opportunity to see people through the lens of forensic services, child and adolescent, substance use, and acute psychs, well-rounded program.
Yeah, Jackson is a good training ground,
It-
whether they're UMC or, yeah.
They have an excellent.
We see a little bit of everything, so.
And then that's that first page handout. The other slides, one thing that I just did want to mention is some future goals that we do have for the fiscal year we're in FY24. We do want to have a focus on increasing crisis bed availability. The ARPA funding that you provided will add 60 more crisis beds in the state. So increasing that availability and making sure they are utilized appropriately and enhancing that utilization.
How close are we for that to be be utilized?
So those 60 beds, we've been working very closely. Mr. Breland, our Chief Financial Officer, has been working very closely with DFA and Horn The majority of the ARPA funds that we received will be sub-granted out. So they're not going directly to our programs, they
Right.
go to community providers.
Right.
So they're in the final stages of working on the assurances, the grant agreements to get that out. Region 8 will be, they have a new 16-bed, the funding for another 16-bed crisis stabilization unit because they're always full. And they are working with the county to secure a location and be ready to go when the funding comes out. The others are as well. The funding is, it's another 16-bed unit, for example, with Region 8, but then some of our crisis stabilization units may have had 8 beds or 12 beds, and this funding would bring them up to 16. Can't have more than 16 because of what's called the IMD exclusion, which is with CMS, but it would bring them up to that 16 beds. So we're working through that. Also coordinating 988. I'm not sure how much you may be aware of that, but the National Suicide Prevention Lifeline on July 16th, it transitioned to a 3-digit number, which the goal is for this to be a behavioral health crisis line. So it would be like 911. Is for healthcare, it would be 911 for behavioral health. So we have 2 amazing Lifeline call centers in the state. We have one of the highest, top 10 highest in-state answer rates in the nation at our call centers, and coordinating that effort and expanding that effort to make sure that when you need to talk to a trained counselor, you can call 988. You'll be talking to somebody in the state. And if you need additional assistance, that mobile crisis team can be dispatched out.
But how many people that want to take their own life know to call 988? That's been my concern to start with. And my personal opinion is we need a way to route 911 to 988 or something, because people don't know to dial 988. I mean, I don't get it. I truly don't get it. You don't know to dial up 988 if you want to kill yourself. You just don't know.
So it's twofold there. A lot of awareness has got to happen. Nationally, they're doing a lot of advertisements, pushing it out, and we're trying to start that here in Mississippi too. But we're also working with the 911 coordinators. Ms. Storr and I, she's our chief of staff. We went and spoke at the 911 conference for the dispatchers. So it's making sure that
I think if we just coordinate with dispatchers and there's a way for them to transfer that to 988, that would make a huge difference. If they feel like that the call needs to be transferred to 988, because I just feel like it's going to take a long time before people know. People still don't call 811 to dig. So, how are they going to call 988? That's just, and I've heard it from a lot of people in my area, but I appreciate the effort, but I don't know how much that's going to help.
I think a lot of it focuses on awareness, making people aware of it, and then the coordination. You're exactly right. And making sure that we can expand access to addiction treatment services as well. We know substance use is on the rise, so having those services available when they're needed, focusing on availability of crisis services for people with IDD and for children and youth. And then the last thing I just wanted to highlight was the forensic service unit at Mississippi State Hospital. A lot of times when you get calls about someone waiting in jail, it's not acute psych. They're not waiting on a state hospital bed. It's forensic services. So as you know, the state had 35 beds for many, many, many years. So you funded the building or renovation of an old building at State Hospital. That will be an 83-bed forensic unit. So it's a 500-day project. They began in December. But in the meantime, we've also transitioned some of our other beds for lower security, don't need maximum security. So we're increasing that number on the forensic side, even as we speak. But we're real excited about that unit getting started, and hopefully we'll see, with no delays, in 500 days, a beautiful 83-bed forensic unit, and we can relieve some of that stress that is on the jails and law enforcement for competency evaluations and competency restoration. So ultimately, we want to continue to strengthen and improve the system. A lot of progress has happened. There's still gaps and there's still things that we need to work on, and we know that, and we appreciate the support from the legislature that we've received and moving forward as well to address some of these issues.
Well, I've definitely seen progress through the years that I've been here, and I appreciate the work and the collaboration. But I want to just bring up one thing that I continue to get complaints about, and I want to know truly how much oversight y'all have and how much direct communication. The contractors that y'all have for the group homes and communities and stuff, I'm still getting complaints about that, people running away from the group homes and beating on people's doors. And, I could show you just tons of screenshots that people send me, about what's going on in the neighborhoods, that they're not adequately being supervised. And I know we've had, lawsuits in the past and stuff. And I mean, I sat down with Diana when she was in your shoes and still having the same issues. And I get less complaints about the day programs, but I still get complaints about the day programs. So I think I rarely ever get a complaint from a state-run facility, and others may, but that's one thing I can say. I rarely ever get a complaint from a state-run facility or from something that's directly related to the community-based mental health. It's more of the private contractors that I get complaints from. So I just wanted to reiterate that. And I think Diana told me, she's like, well, we don't have them lined up out there to serve our needs. And I think that's an area that we still need to work on is that, because ultimately, even though it's private contractor, it comes back to us. And I'm the one who gets the calls that says somebody's in the middle of an intersection in traffic, or, they're beating on somebody's door in the middle of the night, screaming and hollering that they want a Coke or whatever it is. And the thing is you don't want something tragic to happen because one of them is out beating on somebody's door in the middle of the night and somebody's scared and winds up hurting somebody. So I just wanted to bring that, back to the forefront, that we still have a lot of work to do in that area. And, it's not easy to solve, but, and the Justice Department says that's where we have to move to, is community-based mental health. But I think that there's work to be done there.
Well, I would love to sit down and talk to you
Yes.
specifically to
Yes.
learn if it's a private provider that we may certify, or maybe we don't certify them, or if it's a community program that we fund,
Yeah.
and learn a little bit more and dig into.
I definitely will. And I mean, I know that in my small area, if I'm hearing it, that other people have to be hearing it and, in their areas too. So we will definitely talk about that. And I appreciate the progress, because y'all have made a lot of changes that have been very positive. And the fact that there's not that many people sitting in jail anymore waiting is a huge bonus.
My hope is that when I come to you next year, there'll be even less, and same way on the forensic side.
Do any of my members have any questions for Wendy? Senator Hobson.
Thank you, Madam Chair. And I think your questions and inquisitive nature on these issues is important, because I think there are a lot of things. Mental health, I think, is an area where we all get complaints, and not complaints in the sense, Wendy, that they're complaining about you, but just there are people that are out that need care and need treatment. And I think we're doing a much better job than we were when I first got here. And it's definitely improving in a great way. I'm looking at and hearing some of the requests you've got for beds around the state at the crisis stabilization units or in other areas. But are those, I think you're seeking general funds, but is there anything that would preclude the use of ARPA funds for those?
It could all be. I mean, this could be used with ARPA funds. I mean, so the 60 beds that y'all funded last year with the ARPA funds, I mean, this is just in addition to that, because this is IDD and children and youth specific, but ARPA funding could be utilized.
Okay. Have y'all checked that to make sure? I haven't had time, and I'm just catching it now. Have you checked to make sure that there's nothing in the ARPA requirements and guidelines that would preclude you from utilizing it that way?
We can double check that as well, but it shouldn't be, since it's crisis stabilization and it's already been through the HORN process with crisis stabilization for adults. So you want to speak to that?
I would say that I don't think the context of the service is in question, because public health has a lot of flexibility with ARPA funds. I think it's going to be more of a recurring, how do we make sure, number one, the things that we've already proposed and you all funded, how do we kind of coordinate that, evaluate them? And then if they're not successful, that would be something like what you're talking about, Senator Hobson. I think we would probably look at shifting over to this instead, but we've always got the recurring issue of those services staying in place at some point, even if it's 4 years from now.
Yeah,
So I agree with what Senator Hobson says. Go ahead and follow up.
Well, I think there may be an area where we can get to where you need to be. Some of those costs, I recognize that some of those can be general recurring funds, because you're going to have, if you add 4 or 8 beds, you're going to have people that monitor. I mean, it's certainly a personnel issue in addition to some maintenance efforts, but I think that could be minimized with, the collaboration and minimized by the collective nature. You may not need any additional personnel. You may have a little bit of additional maintenance, but it could be much less when it's just an economies of scale issue when it comes to the further treatment. But anyway, that's something we can talk about, Madam Chair, but thank you.
And on the forensic unit, once y'all get that open, that's going to be a big staffing issue too, that's going to be recurring.
Yes.
And that's not in this budget request. It's what the budget writers are telling me. So we need to be planning for that for, what'd you say, 500 days?
100 days from now.
So, and look, I know that I met with our community college, well, at least my community college yesterday, and, they have a huge allied health program, and they basically say they could double the amount of people that they train if they had the facilities and the staff and the wherewithal to do that. So I think the more that we can coordinate with our other state entities, like our community colleges, our workforce development, that we could maybe coordinate like that and fill some of these needs. And I know that's what the Office of Workforce Development is doing for private sector, but I think we could utilize that same thing on a state level and do a better job of training our own folks and knowing where that they're going to go in the pipeline. And, and that's something I would suggest to y'all, communicate in the health department as well. Dr. Edney, he needs all those nurses communicate with these community colleges, especially the ones that can get them out in a year or two and have, some type of incentive or something for them to go into these state agencies, because we honestly, with the PERS report that we just got, we need to add more employees. And I think that would serve a lot of needs if we could coordinate with these community colleges, allied health programs, and channel them into the jobs that we need in our agencies. So I think there could definitely be some coordination and work there. It's not like reinventing the wheel, but I think we could make some huge progress in a hurry to try to get these folks a job and know that they have a job in Mississippi. Many of them want to stay, because sometimes they're older people that, have decided that they want to go into the healthcare field because of the good money and, whatever. And if it's close to home, they might be willing to take a little less money if they got a family that they don't want to uproot. So just wanted to mention that to y'all, that maybe y'all could reach out and start talking to some of our people that train these allied health professionals. Any other questions, comments? Okay, do I have a motion? Thank y'all so much. And y'all know, y'all can contact us anytime. We don't have to be sitting in here in a budget hearing. So we might not be calling you, but if you need to call us, don't hesitate. Thank you.
Vice versa.
Y'all have a good weekend.